Hello, this is the mini lecture that accompanies Chapter 39. As part of Section 3, General Neurosurgery, Part 3, Geriatric Neurosurgery, we will be discussing Chapter 39, Brain Tumor Management in the Geriatric Patient. My name is Or Cohen-Inbar, and I'm on staff with the University of Pittsburgh Medical Center, located in Western Maryland. Life expectancy continues to rise exponentially, with the elderly population subgroup increasing fastest, forming a growing treatment challenge. Of the population, the elderly patients, those above 60 years old, subgroup increases at the fastest pace ever, projecting a 2.9% per year increments until the year of 2050. For the sake of definition and further discussion, the aging patients, defined as those over 65 years, the aged, defined as those that reached and passed the age of 70 years, and the super-aged patients, those over 80 years of age, have aging rates that are 7 to 14, 14 to 21, and over 21% respectively. The growing geriatric population forms a growing challenge for physicians of all doctrines, including neurosurgeons. Elderly patients are more vulnerable to stressors stemming from age-dependent decreased physiological reserves. The concept of frailty has emerged in recent years as a clinical tool helping us to gauge overall health status and risk of adverse events in aging patients. Frailty is a tool helping to gauge that, functioning as a measure of functional and physiological vulnerability. Frailty was shown to exhibit a linear relationship with both poor survival in the elderly as well as a poor functional outcome. Contributing factors have been proposed and discussed by many. Age, functional status, and provider impression, or a combination of these factors, were all reported as measures to classify patients as frail. Comorbid diseases burden on frailty can be assessed using the Charlson Comorbidity Index. Sheehan et al., as well as Michaud et al., reported a positive association between body mass index and frailty. Others reported a correlation between frailty and both body mass index as well as serum albumin. Isobe et al. Reported a positive correlation between age, preoperative BMI, and serum albumin, as well as a skull-based tumor location as risk factors for deterioration of functional capacity. The pathophysiology underlying the concept of frailty can be outlined using one of two commonly applied models. The phenotype model, in which frailty manifests as a decline in lean body mass, strength, endurance, balance, walking performance, and low activity. Thus, general reserves and stamina-related scores assess this patient. In the deficit model, summing up of impairments and clinical deficits, based, for example, on the Canadian study of health and aging, in which frailty index was validated for use with retrospective data. This score was shown to predict postoperative complications, morbidity, as well as mortality after neurosurgical procedures, both cranial and spinal. The Canadian study of health and aging modified frailty index is constructed of 11 variables with 1 point given to each variable present: difficulty with activities of daily living, history of diabetes mellitus, lung or respiratory disease, congestive heart failure, myocardial infarction, other cardiac disease, arterial hypertension, clouding, delirium or cognitive impairment, history of transient ischemic attack, history of stroke, or peripheral vascular disease. We present a short discussion focusing on unique features of the elderly neurosurgical patient, which merit specific clinical considerations. 3 common neoplastic pathologies will be presented and discussed in depth: benign meningioma, glioblastoma multiforme, and we will also touch some on brain metastases. Meningioma, thought to arise and originate from arachnoid capsules, is the second most common primary brain tumor. The risk of developing meningioma increases with age, dramatically so after the age of 65 years. Meningioma accounts for 13 to 33.8% of primary intracranial tumors, more so if post-mortem findings are included in the analysis. The increasing overall life expectancy, coupled with improved and available modern imaging techniques, results in neurosurgeons more frequently diagnosing incidental or asymptomatic intracranial meningiomas in elderly patients. Careful surveillance is recommended, since predicting a specific meningioma's growth pattern and clinical behavior over time is virtually impossible. Meningioma in the elderly patient has been defined by some authors as a separate clinical entity, accounting for the different cellular proliferation, vascularity, as well as intratumoral hormonal profiles which were noted in this group. Among the different techniques or approaches to battle meningioma, three are mentioned: a gross versus subtotal resection of a tumor, stereotactic radiosurgery, or a combined approach coined as adaptive hybrid surgery, in which a planned subtotal resection is followed by a planned stereotactic radiosurgery or radiotherapy to the surgical residual. We will discuss all this shortly in the frame of the geriatric patient. Microsurgical resection has classically been referred to as the primary treatment option for intracranial meningiomas. Despite continuous improvement and advances in both operative techniques and equipment, with related decrease in surgical morbidity reported in recent studies and recent decades, a complete and safe resection with minimal surgical morbidity and preservation of neurological functions is not always feasible. Perioperative morbidity in the elderly patient undergoing a complete resection of meningioma has been reported to range from 11 to 52%. The incidence of temporary and permanent cranial nerve deficits was reported to reach 44 and 56% respectively. Surgical mortality in elderly patients has been reported to be as high as 45%. A skull-based lesion location confers an even worse prognosis in the elderly patient population. Incomplete resection can lead to lower local tumor control rates, tumor progression or recurrence, morbidity, as well as mortality. Which elderly patient will benefit from a surgical resection of his meningioma? And thus I am referring only to those lesions in which resection is technically feasible. What patient profile subpopulation will benefit from an aggressive approach in terms of overall physical and functional status? Different studies have been conducted in an attempt to better define such a patient and set treatment guidelines. Godfrey and Caird reported no difference in the clinical presentation, progression of neurological deficits, or cognitive impairment in a cohort of 111 elderly patients compared to younger patients. Drummond et al., in a review by Brigham Women's Hospital, reported no difference in post-operative survival between age groups after resection of a meningioma. Further validation was offered by Roser et al., reporting a cohort of 43 patients aged over 70 years of age, analyzed and matched in a retrospective study to a cohort of 89 younger patients in terms of tumor size, histology, symptoms, recurrence, etc. The authors reported no significant difference in functional outcome manifested in the Karnofsky Performance Scale in different American Association of Anesthesia ASA grades. Brokinkle et al. Compared long-term prognosis and survival after meningioma surgery in elderly and younger patients in a cohort of 500 patients, reporting no significant difference. The authors concluded that elderly patients with surgically treated meningioma do not suffer from impaired survival compared with age-matched general population. Ikawa et al. published a comprehensive review of evidence regarding surgery in elderly patients with meningioma, discussing 24 papers and a total of 9,987 patients, segregated based on the definition of elderly age, evaluated during 1978 to 2013, with a follow-up duration ranging 2 to 25 years. Ikawa et al. Reported recurrence rates ranging 0 to 24% during follow-up durations of 2.8 to 15.6 years. Local control rates were similar among elderly and younger patients. Elderly patients, however, showed a higher frequency of atypical and anaplastic WHO grade 2 and 3 meningioma pathology. The histopathological diagnosis serves as a most serious challenge because this non-benign histology is known to be influenced prognostically by age, i.e., older age is an accepted negative prognosticator in patients with atypical and anaplastic meningioma, posing a significant risk for recurrence as well as dramatically shorter survival. Stereotactic radiosurgery is a well-established approach harnessed in the past decade for treating upfront or as a complementary tool, i.e. in the frame of adaptive hybrid surgery or as a salvage procedure for those inaccessible, recurrent, or incompletely resected meningiomas. Stereotactic radiosurgery has also been utilized in large inoperable lesions close to critical neurovascular structures. It has been shown to be as effective as microsurgical resection in terms of attaining local control. The safety, efficacy, and patient-friendly design of stereotactic radiosurgery have been demonstrated in the control of benign lesions and tumors, more so for lesions under 3 centimeters in largest diameter or approximately 10 milliliters in volume, having distinct margins and sufficient distance from neurovascular critical structures to permit the safe delivery of an effective target dose. The overall reported 5 and 10 years actual tumor control rates after stereotactic radiosurgery for benign grade 1 lesions are 91 and 88% respectively. Numerous authors reviewing very large independent stereotactic radiosurgery meningioma cohorts repeatedly reported age not to influence prognosis in patients treated with stereotactic radiosurgery. Focus et al. Reported a 5-year rate of local control, overall survival, and cause-specific survival to be 92.9, 88.7, and 97.2% respectively. Conciolca et al. Reported that long-term tumor control rates were sustained even when reviewed over 10 years after stereotactic radiosurgery. What validated tools are available for predicting a favorable outcome for elderly patients harboring meningiomas, treated with either microsurgical resection, stereotactic radiosurgery, or both? The term favorable outcome serves as a composite outcome parameter, encompassing both tumor volume control as well as preservation of functional and neurological outcome. Several large studies suggest that increasing age serves as a negative prognosticator in patients undergoing microsurgical resection of a meningioma, while others report that clinical radiological features as well as functional status play a larger role as risk factors. Of note, there are risk factors and risks associated with the conservative or observation or wait-and-see approach in the elderly patient, as well, which merit notice, as the potential possibility or to improve one's health by waiting is much less feasible in this patient's age group. Several scoring systems have been constructed in an attempt to offer risk stratification for surgical resection in elderly patients with meningiomas. 5 such grading systems are presented in this chapter. The Geriatric Scoring System, or GSS, was presented in 2010 as part of a detailed analysis on a cohort of 250 elderly patients over 65 years of age, operated for intracranial meningiomas. Comprehensive analysis revealed 8 significant prognostic indicators which are implemented into a scoring system, the GSS. In the GSS, 8 clinical and radiological parameters on admission are logged. These 8 parameters attempt at a more comprehensive patient and lesion evaluation and can be broadly viewed as 5 patient-related parameters and 3 lesion or tumor-related parameters. Each of these parameters is assigned a score ranging 1 to 3, resulting in a score that total ranges 8 to 24. 7 different short-term and long-term outcome parameters were tested using the Geriatric scoring system. A GSS score over 16 was found to be associated with a favorable outcome significantly. One key advantage offered by the GSS lies in the modifiable nature of some of its parameters. Better control of comorbidities, for example, or of peritumoral edema may result in an increase in the GSS score and its related improved outcome and prognosis. The GSS score was further validated on a separate surgical cohort of 120 patients aged over 65 years, with the same 7 outcome parameters along with admission length parameters tested against the GSS score with a cutoff of 16. A GSS score over 16 was similarly shown to be associated with a significantly more favorable outcome. The GSS score was later challenged and validated in a separate cohort, independent of patients who were treated with single-session stereotactic radiosurgery using gamma knife for their intracranial meningiomas. The cohort comprised of 323 patients. A GSS score over 16 was found to significantly correlate with post-stereotactic radiosurgery functional status and tumor control rates. The GSS score was validated by multiple other groups as well in the past few years, as depicted in the chapter. The table presented shows a brief comparison between the different grading systems discussed in the chapter. All grading systems reviewed show correlations with mortality and other outcome parameters. The CRGS, GSS, CLAS, and CCS scales do not consider patient sex being an unchangeable parameter and thus less valuable for pre-operative risk stratification modification. The scale grade does not incorporate tumor size or pre-operative neurological deficits, and it defines location subjectively, critical versus not critical. The CRGS, CLAS, scale, GSS, and CCS all consider comorbidities, whereas the CCS does not incorporate any of the tumor's radiological features. Glioblastoma multiforme is the most common primary brain tumor in adults, with as much as 6,000 new elderly patients diagnosed annually in the United States. GBM incidence has been on the rise in the recent decades, with the majority occurring in those over 70 years of age. This increase is expected to double the number of patients over 65 years with GBM in the coming 2 decades. Age serves as both a risk factor for GBM development and as a negative prognostic factor in GBM, which features a relentless course with progressive and rapid loss of neurological function, at times occurring during treatment. Advanced age and poor performance status are negative prognosticators. Despite reported overall median survival of newly diagnosed GBM of 15 months, it is inherently worse in elderly patients. As evidence, in the radiation therapy oncology group recursive partitioning analysis studies, in both the original and the updated reports, age of over 50 years was most predictive of decreased survival in GBM patients. Despite accumulating evidence the optimal management of elderly patients harboring glioblastoma multiforme is still unclear. The general concern that any treatment may be less effective and more toxic in the elderly patient drives these uncertainties. Elderly GBM patients have historically been excluded from large controlled trials. This was due in part to the presumed likelihood of a decreased sustained treatment response or a prolonged good outcome. Cloney et al. Reported that frail patients receive less aggressive intervention, have longer hospital stays, and more complications. It is clear that treatment decisions should be made in the context of a comprehensive geriatric assessment. Elderly patients with a good functional status may benefit from a more aggressive approach, while other frail patients may be considered for less aggressive approaches such as hyperfractionated radiotherapy or single-agent chemotherapy. The current standard of care for patients with glioblastoma multiforme of all ages was coined by Stoop et al. In their pivotal study, they showed a survival advantage for patients receiving concurrent and adjuvant temozolomide in addition to standard course of radiotherapy. Yet, applying these recommendations for the elderly is challenging, since the effectiveness of concurrent and adjuvant temozolomide decreases with age in terms of added benefit over the radiotherapy group alone. Genetic typing has been taking an increasing role in tumor classification, as manifested by the recent WHO GBM classification system. Genetic tumor markers serving as both prognosticators and predictors guiding treatment differ in incidence and utility in the elderly GBM patients. The isocitrate dehydrogenase gene mutation for this glycolytic enzyme correlates with a better tumor survival compared to the wild type, making the tumor somewhat more radiation sensitive. The IDH mutation is much more common among younger adults as compared to the elderly patients, and as such suggests a more radiosensitivity of those tumors in the younger group. The MGMT promoter methylation mutation results in a GBM cell that has a greater sensitivity to alkylating agents such as temozolomide as well as radiotherapy. The presence of the MGMT mutation suggests that the tumor may be more sensitive to both, and it's shown to have a higher incidence in elderly patients' tumors. Knowledge of the MGMT status mutation in a specific patient may support the use of chemotherapy or radiotherapy as single agents among those patients. The relative frequencies and prognostic value of different genetic markers differ among patient age groups. For example, p53 mutation and the epidermal growth factor receptor amplification possess potential opposite prognostic values in a young patient compared to an elderly GBM patient. Phosphatase-tenzene or PTEN mutation occurs significantly more frequently in elderly patients. The indoleamine dioxygenase 1, IDO1, implicated in glioma, is significantly upregulated up to 400% fold in aging brains, suggesting for age-related factors predisposing or protecting from gliogenesis. The correlation between GBM patients' age, the extent of resection, and clinical benefit is still a matter of clinical debate. Norbakish reported a cohort of 20,705 patients with GBM in the SEER registry from 1998 to 2009. The percentage of GTR, gross total resection, achieved decreased in a stepwise manner as a function of age. GTR was shown to be associated with improved overall survival, even in elderly patients with GBM. As such, The authors recommended that surgical decisions be individually tailored to the patient rather than adhere to age as a sole determinant. Gross total resection, as said, is associated with improved overall survival, even in the elderly GBM patient. Although the overall outcome in elderly GBM patients is poor, craniotomy and attempted gross total resection carry a reduced risk for mortality and modest benefits in terms of functional independence and survival versus biopsy alone. Several large population-based reports suggest that both gross total resection and subtotal resection is associated with improved survival in elderly GBM patients, similarly to younger patients when compared to biopsy alone or to conservative management, with the gross total resection subgroup demonstrating the greatest benefit to survival. Radiotherapy was shown in level 1 evidence to impart a survival advantage over best supportive care with respect to overall survival, 7 versus 4.25 months, in elderly patients over 70 years of age. Yet, the optimal dose and regimen is not well established. Conventional schedules with 25 to 30 fractions were compared to hypofractionated schedules with 10 fractions or to other 3 or 5 weeks schedule and were found equivalent in terms of clinical effect. Thus, the management of elderly patients harboring GBM is evolving from a previously indiscriminable minimalist approach to a more individualized care. Evidence supports surgical GTR or gross total resection in elderly patients who are good surgical candidates. Adjuvant chemotherapy and radiation therapy are well tolerated and appropriate for these patients. Further insights into the molecular drivers of elderly glioblastoma multiforme, an increased focus on comprehensive geriatric assessment, and ongoing studies aimed to clarify the role of concurrent treatment is mandated. Discussing brain metastases in the elderly patient. Advances made in the diagnostic as well as treatment of systemic cancers result in elderly patients harboring neoplastic disease surviving much longer. The longer cancer patients survive, the more likely they are to develop brain metastases. Clinical outcomes of stereotactic radiosurgery for brain metastasis patients over 80 years of age were not found unfavorable or different from the younger age group patients, justifying their use regardless of patient's age. Yet, the use of whole brain radiotherapy, a previously gold standard treatment but now a complementary measure, which has a known related toxicity, was noted to be higher in the elderly population treated with it. Comparing different clinical risk stratification tools, the basic score for brain metastases, or BSBM, is the only scoring system applicable for patients over 65 years of age, unlike the recursive partitioning analysis or the GPA. The BSBM, however, suffers one major weakness, not factoring any brain metastasis specific factor, grading also known brain metastasis related factors as well. Yamamoto et al. Suggested a modified system, the elderly specific or ES BSBM, validated in 2 large cohorts of patients with brain metastasis treated with stereotactic radiosurgery. 2 prognostic factors were noted to strongly impact survival after stereotactic radiosurgery in the elderly population tested. These are the number of brain metastases and the cumulative tumor volume. These parameters appear in multiple discussions in the literature comparing the relative importance and dominance of the overall tumor volume burden versus tumor lesions number, suggested both as prognostic and crucial. The elderly specific BSBM reflects adding scores of either 0 or 1 to these factors, shown to significantly improve the predictive and prognostic value of this index. With regard to age-related dose adjustments and adapting different treatment protocols for the elderly population, these are relevant mainly for the stereotactic radiosurgery treatment modality. A heated discussion exists in the literature as to whether lesions should be treated based on their own biology, hence those related to pathology and not influenced by patient's age or other parameters, versus a more holistic view looking at the disease biology and patients together, allowing for some age-related adjustments of decisions. Radius et al. Compared two stereotactic radiosurgery dose schemes, a low dose of 16 to 18 grays to the margin versus a high dose of 20 grays to the margin in a cohort of 95 elderly patients for different outcome parameters. Intracranial disease control rates at 12 months and 12 months new lesion development rates were not noticed to differ significantly. Local lesion control rates were 55 and 81% respectively. Overall survival at 12 months was 29 and 31% respectively. Thus, the low-dose stereotactic radiosurgery schemes were not associated with significantly inferior outcomes in the elderly patient group. The elderly serve as the largest and most rapidly growing patient group, both generally and in neurosurgery. Physicians should be knowledgeable of the profound effect of exposure to stressors in frail patients and potential associations with poor outcomes. Future research should look at how frailty, once identified, could be modified in order to develop preventive strategies or minimize adverse effects.